Welcome to ATCM, the Emergency Medicine channel. As part of EM Rapid, now we are going to discuss about common thyroid disorders in emergency room. When we discuss about thyroid disorders, we know that there are two types of important thyroid disorders. One is hyperthyroidism and another one is hypothyroidism. In that itself, we have thyroid storm and MYXEDEMA coma. We will see the both emergency conditions in thyroid disorders. First, we discuss about thyroid storm. We know that when the thyroid hormone produces excessively, patient will have hyperthyroidism. When it is becoming uncontrolled manner, then the patient develop thyroid storm. Hyperthyroidism occurs when thyroid gland produces too much thyroxine, that is a hormone produced from the thyroid gland. We know that the action of thyroid hormone is it increases the metabolism in our body. When it is becoming uncontrolled manner, the metabolism will increase. Patient can have tachycardia, weight loss, or so many abnormal problem patient can develop. Normally, hyperthyroidism is seen in Graves' disease. That's a type of autoimmune disease. Toxic multinodular goiter with increased thyroid hormone production. Toxic adenoma in the thyroid gland. Thyroid carcinomas. Mutation of TSH receptor in the body. Struma ovary. Iodine excess, but these things are not very common in clinical practice. The most common cause for hyperthyroidism is Graves' disease, and some patients can have toxic multinodular goiter. Rarely patient can present with thyroid carcinoma also. Secondary hyperthyroidism is also very rare. TSH secreting pituitary adenoma, gestational thyrotoxicos. These things are very rare. We can see the clinical findings in hyperthyroidism. Patient can have exophthalmosis, the eyes will be bulged out. Ophthalmoplegia can be there in some patients. Some patients can have goiter, enlargement of thyroid gland, especially in multinodular toxic goiter. Most of these patients will have tachycardia. Resting tachycardia is most important. Patients who have already heart disease can have angina. Many patients with hyperthyroidism can have atrial fibrillation. High BP can be observed in some patients. Oligomenorrhea, diarrhea, sweating, tremors, warm hand, proximal myopathy, pretibial myxedema, angle swelling. So these are the common things. General findings, many patients can have unintentional weight loss. Without any diet restriction, patient can have weight loss. They can have more appetite and again weight loss can be there. Heat intolerance, anxiety, irritability, tremors, all these things are there in hyperthyroidism. Just opposite can be there in the hypothyroidism that we'll discuss afterwards. You can see in this slide, patient is having ophthalmoplegia and exophthalmosis. You can see both upper part and lower part white color around the your iris. So exophthalmosis and ophthalmoplegia can be there in many patients. Now, when we have a patient who is having hyperthyroidism, the investigation of choice is always T3, T4. In that, free T4 is one important investigation. Free T4 will be elevated, or T3 and T4 will be elevated. In patients who is having hyperthyroidism, TSH will be suppressed. If the patient is having hypothyroidism, TSH will be elevated, but here TSH will be suppressed. So when we have patient who is having hyperthyroidism, patient can have a lot of neurological findings, like patient is having sweating, anxiety, tremors, and patient can have tachycardia also. Beta blockers are the best choice to relieve all these symptoms. So propranolol can be started. Propranolol, one advantage is that it crosses the blood-brain barrier. So all these conditions where the patient is having neurological findings, propranolol is a very good beta blocker. 20 to 40 milligram regular tablet can be given 6 hourly, or you can give long-acting drugs 40 milligram SR tablets, BD can be given. Other alternatives are atenolol or verapamil can also be used if propranolol is contraindicated, or if the patient is having asthma and all, beta blockers may be contraindicated. Verapamil or diltiazem can be tried to control the heart rate. Now, for reduction of thyroid hormone synthesis, thiourea drugs like carbamazole 10 to 20 milligram 8th hourly can be started. It's a long-term process, minimum 2 years patient have to take this type of drugs and slowly reduce the dose and ultimately stop the drug. Propranolol is a beta blocker. It can be used as 20 to 40 milligram every 6 hourly, or long-acting preparations are available. So you can give BD doses. Even it can be used in pregnancy also. Patient who is having asthma or asthma induced by beta blockers, calcium channel blockers like verapamil or diltiazem can be tried to control the heart rate, but it may not control other symptoms like tremors, palpitation, and all. Carbamazole is one drug which can be used in hyperthyroidism. It should be started with 10 to 20 milligram once daily initially, then it can be given 3 times daily. Slowly, we have to reduce the dose. That is very, very important. Minimum maintenance dose may be after 3 months or 6 months. It is 2.5 to 10 milligram once daily. Methimazole is an alternative for carbamazole. So these drugs should be continued, and patient should be taken it for a longer period. Like many patients require it for at least 2 years. Very rarely patient can develop agranulocytosis like neutropenia can be there. We have to warn the patient before starting this drug. Propylthiouracil is another drug which can be used during pregnancy and breastfeeding. And we can start 100 to 200 milligram TID. Then maintenance dose is 100 to 100 milligram per day. So that can be continued. It can be given in pregnancy also. Now, thyroid storm is an acute medical emergency due to hyperthyroidism or exacerbation of hyperthyroidism. Medical storm can be there in patients who is having acute illness like any sepsis, stroke, trauma, diabetic ketoacidosis, or after radioactive therapy. Surgical storm normally seen after surgery related to thyroid. So after thyroidectomy and all, we can see the patient is developing increased amount of thyroid hormone released to the blood and patient develops thyroid storm. Clinical features, it is like an exaggeration of the thyroid hormone overproduction. Patient can have fever, hyperthermia, delirium, seizures, coma, severe vomiting, diarrhea, jaundice, cardiac failure, arrhythmia, atrial fibrillation. Most important thing is tachyarrhythmia and cardiac failure. So when we talk about investigation, again, the most important investigation is TSH, free T4 and T3. Hyperglycemia can be seen in secondary to catecholamine-induced inhibition of insulin release and increased glycogenolysis. Hypercalcemia may be occurring due to hemoconcentration and enhanced bone resorption. So these are the common investigations should be done in thyroid storm. Many patients present with tachyarrhythmia and cardiac failure. Whenever patient present with unexplained tachyarrhythmia, atrial fibrillation, cardiac failure, thyroid investigation should be done in these type of patients in emergency. So the management is again the same line of management, but we have to treat the patient aggressively. So cooling of patient is very, very important. Rehydration should be given. IV fluids are required to rehydrate the patient. Cooling blankets. So we have to correct the problem in this patient, like sepsis should be corrected with antibiotic, myocardial infarction should be treated. So all these like aggravating factors should be treated properly. Digoxin is one drug which should be used in patients with atrial fibrillation and cardiac failure. Hyperthyroidism or thyroid storm can present with atrial fibrillation and cardiac failure. So digoxin has got a role there. So digoxin can be tried. The only indication for digoxin nowadays is AF in cardiac failure. Otherwise, previously we used to give digoxin for almost all types of cardiac failure, but nowadays, because of its safety profile, it is indicated only in patients who are having atrial fibrillation with cardiac failure. IV propranolol can be tried. If IV propranolol is not available, we can use any other beta blocker like metoprolol or any other beta blocker, or IV verapamil can be tried, because patient will have supraventricular tachycardias, tachyarrhythmias, or atrial fibrillation with cardiac failure. Remember, the cardiac failure is due to the tachycardia or atrial fibrillation, not because of any other thing. He is not having any dilated cardiomyopathy. If you control the tachyarrhythmia, probably we can reverse the cardiac problem. So we can give any beta blocker or calcium channel blocker to control the heart rate. That will relieve the cardiac failure. Other cardiac failure measures like Lasix or any other method can be tried here also. So routine cardiac failure treatment will go with standard guidelines, but IV beta blocker should be tried in this type of patients. Propylthiouracil 600 milligram loading dose, then 200 to 300 milligrams 6 hourly should be continued. That blocks the T4 to T3 conversion in the peripheral tissues. Methimazole can also be tried. Now, other drugs which can be tried in hyperthyroidism is or thyroid storm is iodate sodium 500 milligram per day orally can be helpful in if started 1 hour after the first dose of propylthiouracil. Iodine is given in 1 hour after the as Lugol solution, 10 drops 3 times daily orally, or sodium iodide 1 gram intravenous slowly. Iodine blocks the release of T4 and T3 from the gland. That is very important. In acute settings, we have to prevent the release of T4 and T3. Hydrocortisone can be tried 50 milligram orally every 6 hours. It should be used to reduce the T4 to T3 conversion. Cholestyramine can reduce the enterohepatic recycling of thyroid hormone, 4 gram orally, 4 times daily. Aspirin should be avoided in this type of patients unnecessarily. If the patient is having a compelling indication of aspirin, it can be continued. Otherwise, since the patient is having atrial fibrillation or tachyarrhythmia with cardiac failure, it should not be started. Now we'll discuss about hypothyroidism and myxedema coma. Hypothyroidism is a very common thyroid related disorder. In that, myxedema coma is not very common, but a patient who is having coma with bradycardia, we should suspect myxedema coma, or hypothermia with bradycardia, we should suspect myxedema coma. Hypothyroidism is a condition that occurs when the thyroid gland doesn't produce enough thyroid hormones. It is very common in female patients than men. Classification, again, primary and secondary. Primary is thyroid gland disorder, pituitary or hypothalamus disorder leads to secondary hypothyroidism. Thyroid function test. In that, TSH is very important. So whenever we have a patient who is having suspected hypothyroidism, only TSH is enough to make a diagnosis. TSH will be elevated when the thyroid gland is not working properly or not releasing thyroid hormone. Because of the feedback, TSH, that is thyroid stimulating hormone, will be increased. Normally, hypothyroidism will be treated with levothyroxine, that is thyroid hormone. 1.6 microgram per kg should be started. It should be started as a single dose in the morning. Remember, patient who is having hypothyroidism and cardiac disease or elderly individual, we cannot start this much dose. We'll be starting very low dose. Slowly we'll be hiking the dose. Most of the patients may require 100 to 150 microgram per day. That is a normal dose in many patients. So we start with lower dose in elderly and cardiac diseases because acute tachycardia can aggravate the problem in this patient. So slowly we'll start in hypothyroidism. So levothyroxine 1.6 microgram per kg, single dose in the morning before food should be started. patient should take the tablet every day. After 6 months, after 3 months, patient can test the TSH, and TSH should be towards the lower limit of the normal value. Now, we have already discussed the clinical features of hyperthyroidism with same type of picture previously. Here we can see periorbital edema. So edema around the eyes, edema on the face, husky voice. Goiter can be seen in some patients, but many patients who is having hyperthyroidism or hypothyroidism, you may not see the goiter. Bradycardia, hyperthyroidism, we saw tachycardia and cardiac failure. Here we see bradycardia, pericardial ablation, and cardiac failure. Carpal tunnel syndrome, compressive neuropathy. Menorrhagia, so increased menstrual bleeds, whereas in hyperthyroidism, oligomenorrhea. Constipation. In other condition, we saw diarrhea. Other findings like low metabolic rate, depressive phase, depression, weight gain, cold sensitivity, lethargy, laziness, all these things you can see in hypothyroidism. Myxedema coma is an exaggerated form of hypothyroidism. It's defined as severe hypothyroidism leading to decreased mental status, there is coma, hypothermia, reduced body temperature. Other symptoms related to multiple organ dysfunction. Whenever there is hypothermia, normally patient go to multi-organ dysfunction, whether it is due to cold exposure, alcoholism, or myxedema. All these conditions, hypothermia can lead to a lot of complications because of intravascular coagulation. Patient develops DIC and multi-organ dysfunction. It mainly occurs in elderly individuals with infection. There will not be any fever, pneumonia, cardiac failure, myocardial infarction, GI bleed, CV, all these things induce myxedema coma. But remember, a patient who is having hypothyroidism, who missed the doses of thyroxine, or a patient is not taking thyroid hormone properly and miss the tablet due to some reason, they present with myxedema coma normally. But patient who had never diagnosed as hypothyroidism also can present with myxedema coma due to acute emergencies. Patient can also have low GCS, seizures, hypothermia, hypotension, bradycardia, hyponatremia, hypoglycemia, hypoventilation, respiratory acidosis are the major clinical features in this type of patients. Clinical features we already discussed. Hyponatremia is one of the most common lab investigation we see in this type of patients. But to many patients, it is due to the fluid retention in the body. But some patients can have real hyponatremia also, that should be corrected. Hypothermia can be seen in almost all patients. Hypoventilation can be seen, and patient can develop respiratory acidosis because of carbon dioxide retention. So these are the common findings you can see in patients who is having myxedema coma. Other findings like hypoglycemia occurs due to hypothyroidism alone or due to concurrent adrenal insufficiency due to autoimmune adrenal disease or hypothalamic-pituitary disease. Cardiovascular abnormalities, patient can have severe bradycardia, pericardial effusion, low cardiac output, hypotension, all these things. Mortality rate without treatment is very, very high. It is around 50%. So we should be very, very careful when we are treating myxedema coma. Remember, if we are doing a lumbar puncture, you can see the protein will be elevated in this type of patients. Patient who is having myxedema coma, patient can have elevated CSF pressure and protein, but cells may be normal. So this will be one important cause for albuminocytological disorder. We have seen in we can see the same finding in patients who is having Guillain-Barré syndrome and all. But here, without any CNS abnormalities, you can see proteins will be slightly elevated, but cells are normal. Lab finding, we already discussed that TSH is the one important investigation which will be elevated in hypothyroidism, and here also TSH will be elevated. Serum cortisol should be measured before and after ACTH administration, but it is not practical in emergency room. We can take a random cortisol in patient who is having hypertension and coma. Hypotension, hypothermia, bradycardia and coma, we have to always send TSH and cortisol levels. TPO is one antibody test, it can be elevated in autoimmune thyroid diseases. So if you have doubt about thyroid disorder, we can ask for TPO. If we have a clear-cut case of high TSH, TPO may not be useful in emergency room, but to know whether the patient require lifelong therapy, TPO is a very, very good investigation. If TPOs are elevated, then it's an autoimmune thyroid disorder. These type of patients may require lifelong thyroxine therapy. So TPO can be done anti-thyroid peroxidase antibody that can be done in patients who is in hyperthyroidism and thyroid hyperthyroid coma. Now, management is it's an exaggerated form of OPD management. We give IV T4 or IV T3. IV T4 initial dose is 200 to 400 microgram, followed by daily IV dose of 50 to 100 microgram until the patient can take T4 orally. Or T3 IV initial dose is 5 to 20 microgram, followed by 2.5 to 10 microgram every 8 hourly. If IV preparations are not available, start tablet. Most of the patients may be on these tablets, so we can give the high dose of tablet, like each tablet may be 50 to 100 microgram. You can give nearly 200 to 400 microgram. 4 tablets of 100 microgram can be given through rice tube. That will be equivalent to your IV preparation. Some hospitals may have IV preparation, so try that. Steroids can be given in patients who are having adrenal insufficiency along with hypothyroidism. External warming is very, very important. There are different types of warming methods, rewarming methods are there. But the most easiest thing is give a patient with warm blankets. IV salines can be continued. Infection should be treated aggressively with antifungals or antibiotics or antivirals. Whatever may be the infection, we should treat with antimicrobials.